this is the first ABHIN conference. And yeah, we're trying to figure out, like, how do you work a microphone and how do you, get the internet? And we've had such a team of people getting us here. And there's a lot of important people here, and some of them are speakers, and we have Miss Arkansas here, and we have some fantastic speakers from outside of Arkansas, some national experts, but we also have some Arkansas experts. But the thing that I want you to know is that the most important people here are y'all. You all right here sitting in these seats. And our goal for today is that you get what you need. And it's going to be different for everybody as to what you need, whether you came to get some knowledge, some time away from your regular job, from conversations with people. That's what we hope that you can get from today. We know that it's going to be a blessing for everybody, and it's going to be a great experience. It's already been a great experience for us getting to this day. And this day really started, a lot of the people in the room were at the beginning. And y'all love going to conferences where the leader says, okay, now we're going to do an experiential role play or something. So actually, ABHIN kind of grew out of one of those little activities. So do you have all the little sticky notes to give everybody for this exercise? We are not doing one of those, and we're not going to make you do a role play. But, this ABHIN really grew out of a committee, and I wasn't even at that meeting when it started. For me, it started way back in 2009 when my boss at the VA said, go over to primary care. I was like, what am I supposed to do there? I'm an inpatient psychiatrist. And she was like, well, there's this program, and it's integrated care, but I was like, what is it? And she said, well, just go over there, see patients, and build relationships. And so I would still say today, after all these years, and I'm the nerd that does go to the conferences, I do buy the books, I want to know what did the experts say. But really, integrated care is about see patients, see people, see clients, whatever your discipline calls them, see them, and build relationships. And the relationships with each other are as important as the relationships with the people that we think that are customers. And so that's what integrated care is. But where ABHIN actually grew, there was that CPC Plus thing that most people in here were part of. There was a stakeholder group, Blue Cross kind of was coordinating, and Adam, I'm sure I can just visualize this because he made us do these exercises like, okay, everybody get these little stickies out or go around to this board and say what is important for CPC Plus stakeholders this year. And it was either at the end of 2017, beginning of 2018. One of the things that was needed was behavioral health integration. We all know we needed it, but we didn't know how to do it, so it started a little work group. And so they were having Kim Shuler drive down from Fayetteville, and then my people over at Baptist say, hey, now you're going to have to go to those meetings. I was like, what am I supposed to do at those meetings? Meetings, committees. But it grew, and then just meeting other people. And for me, I met one person that's really instrumental in founding of ABHIN is a person named Jen Y. Her real name is a Basque name, like Iturandombedia. She's from Idaho. Met her at CFHA. I emailed her. I said, hey, you did a great conference. A presentation. What is this? It was my very first Zoom meeting in 2017. So that was kind of at the same time this stuff was happening. And so Jen Y started giving me information. She said, I was like, why are you giving me this? Am I going to end up having to pay you? And she was like, no, I want to pay it forward. And Jen Y is actually one of the advisors for our ABHIN board. She is not here, but she ought to be. And actually, I think because she's doing her own conference in Idaho, the Idaho Integration Behavioral Health Network. We went to their conference. And so our committee started going, man, this BHI thing is big. How do we bring that in a meaningful way that really does translate into helping patients get better, saving cost, saving avoidable costs. We want people to go to the ER if they need to, but if they're not getting what they need, we want to give it to them sooner. And then, so trying to figure out how to do BHI in an evidence-based way. So in Idaho, Gen Y started saying, hey, y'all could do this, y'all could have a nonprofit, and we were like, and I'm like, you'll know Kim and I are kind of yin and yang, and I'm like, yeah, we can do this, we can be a nonprofit, and we can, and Kim's like, oh. So we then became a nonprofit, which is not that easy, but it takes a lot of support. And our first thing is we were like, well, we want to have a conference. We want to have a conference. So back in 2018-19, we were like, let's have a conference. Well, a few years have passed, and we've all learned how to use Zoom. And we've gotten to the point that when Zoom doesn't work, like at our very last meeting, I don't see those people right. It's like everybody's voices were messing up. And instead of freaking out, we were like, oh, wow, this is how Zoom is. But also, you remember our Zoom conference Thursday morning at 7:30. There were 95 people on that conference because we had a great presentation from one of the practices about social determinants of health. Now, all of our webinars like that, they're recorded on our website. So I want you to go to our website if you haven't. And there's 3 years of webinars of truly good information about what is integrated care or pieces of it. So I know I'm trying to why didn't we put a clock in here so I'd know how long I can talk? Because I can talk for a while because I do love integrated care. And I love what's happening here. I love the fact that we have, somebody said, well, who's the audience for this? Well, there are some physicians. There's some leaders from Blue Cross and some of the other payers. There are people who are working in the field as therapists. There's clinic managers. There's care coordinators. There's peer recovery specialists. And there's just people that may not even work in the field, and they're here. And so we know that you'll get what you want here. So ask us if you need something, but also, you never know, just be open. So one of the things I did was to bring, this is in my office at home, it says, may healing be the reality for all who come here. And one of my clinic managers way back in the 90s, before most of y'all were born, I had a practice that was called Our Healing Place. And it was to treat people who had or provide treatment of all types for people who have addictions, substance use, family issues. And so my clinic manager made this, and Our Healing Place, really what we knew is that we were a medical practice, so we were helping people, and we were hoping they were getting healing. But through the process, we knew that we, the staff, were getting healing. And in that practice, it changed me. I grew. And then I moved to another job and another job and another job, and then I have ABHIN. And so really this is my vision. What has already happened in these 3 or 4 years for ABHIN is that I hope that we brought healing to some patients, some customers, some citizens in the state, but also I hope that we brought healing and will continue to people who are the workers. I know that we brought healing to us who are on the staff of ABHIN. It has been hard, really, no blood, but sweat and tears. But we're healing, and we're looking forward to our next conference and whatever that needs to be. So we just want to welcome everybody here. Get what you need, ask us what you need, ask us if you need something and you're not getting that. And just know that this is building forward, and we hope that you get your healing and to take something to go help the people that you're trying to help. So thanks for listening to me, and thanks for celebrating this first conference for ABHIN. And Kim Shuler, I do want to say thanks to Kim. Now, y'all know Kim as a Southern Belle, right? No, she's from Chicago. But I didn't even know Kim when we started, and she's the sweet one of us, and she's the kind. She's a therapist. She always says the right things. Kim is really a strong, smart, wise, business-wise therapist, and has become a friend and is a fantastic leader for ABHIN. If she wasn't already the CEO, I'd be wanting to give her a job offer. But I'm really happy that Kim is here and that she can introduce our next speakers and will be leading us through the day and continue leading ABHIN. So thanks.
Thank you, Dr. Gibson. Thank you all for being here today. Wow, we are so excited. And as Dr. Gibson said, we have been waiting a long time for this day. We actually were getting started right as the pandemic was happening, and so we thought this is going to really slow us down a little bit. If you could say, hey, ABHIN team, have you all worked on Zoom? Really, none of us had worked on Zoom. So it really threw us for a curve. But anyway, here we are. It's taken us a couple of years, but we have our first conference. And we are so excited to be here and share the first Behavioral Health Integration inaugural conference with you all. So, first of all, I want to say thank you for being here and choosing to spend your time with us today, right? Choosing to believe in behavioral health integration, because this is critical. You'll often hear us say there's no health without mental health, and we absolutely believe that. We're all health consumers, and we all have mental health. I always say our head is not disconnected from our body, and so it's important that we're treating the whole person and looking at whole health care. So thank you for being here. Thank you for your enthusiasm. Thank you for your passion, and thank you for your time today. I also want to thank our staff. You'll see our staff, our ABHIN staff walking around. They'll have on these turquoise blue shirts. It'll say ABHIN on the front. If you need anything, please stop any one of them and Dr. Gibson or myself and say, hey, I need something. We're here to help. We want you to be comfortable today. We want this to be an enjoyable day and an enjoyable experience. I also have to say, our team, we have a phenomenal team. We started out, it's just us. And we have got some fantastic people. They truly are the backbone of our organization, and they keep us functioning. And so I am so grateful for our team. I also want to thank the production crew. We couldn't be here without you today. We have a great team supporting us, so thank you all. I also want to thank our sponsors. We couldn't be here without you. We have St. Vincent's, who is allowing us to use this amazing space. So if you see someone from St. Vincent, thank you, St. Vincent's. I also want to say thank you to Blue Cross Blue Shield. They have been supporting us along the way and have sponsored today's breakfast and lunch. So thank you to the Blue Cross team. We appreciate you all. We also want to say thank you to HRSA. We are using our HRSA funds from our ARCOR and FORP grant to put on this conference today. So, thank you all so much. And then I want to just give you a few important details for the day, so this will make your experience and day go smoothly. I know when I'm in conferences, sometimes I'm sitting in the audience and I'm like, I've drank a lot of coffee. How long do I have to sit here before I have to get a bathroom break? So we want you to know, after our first keynote speaker today, we're going to have a 15-minute break, and then we'll go into a breakout session. We have the breakout sessions that will be in this main auditorium as well as the North Auditorium, which is right behind us. After that, we'll have a 30-minute break. We're going to do box lunches in the foyer in the hall, and so everyone will get their lunch, and we'll come back to the main auditorium where we'll have Dr. Maddox do a keynote lunch presentation. After the lunch presentation, we'll have one additional breakout session and another 15-minute break. I want you all to feel comfortable to get up. If you need to go to the restroom, move around. If you have questions, please ask them. I know this feels like a large space, but we're all friends. I feel like we know everyone in here. We've all been working together for a long, long time. So we really want you to feel at home and feel comfortable here today. So I want to ask, has everyone started to get their coffee? Raise your hand. Yes? Woo! Okay. I know some of you had to travel, right? We've got people that have driven 2 hours, 2.5 hours this morning. So thank you for being here, for making it in. I want to say thank you to our speakers that have had to travel here from outside of Arkansas. We really appreciate it. All right. Another bit of important detail, the bathrooms are in the lobby. They're fairly small for the ladies' room, so if those are full and we need additional bathrooms, if you take the first right and go down the hall, there will be bathrooms down that hall. So I think those are all of the important details, and with that, I'm going to have an opportunity right now to introduce our special guest, Miss Ebony Mitchell. She's Miss Arkansas. Ebony Mitchell is a 26-year-old native of Harrison and the first Miss Arkansas from Harrison. As Miss Arkansas, Ebony won a $30,000 scholarship provided by the Sokos Foundation and more than $75,000 in award, wardrobe, transportation, and gifts. She represented Arkansas at the Miss Arkansas competition in Uncasville, Connecticut. During her year as Miss Arkansas 2022, Ebony will make appearances across the natural state promoting her personal platform, A Responsible Digital You. She'll also promote the Miss Arkansas Scholarship Organization while speaking about the goals of Miss Arkansas and the Miss Arkansas system. Ebony is a published author and a 2022 graduate of John Brown University, where she received her master's degree in health administration. She received her bachelor's degree in business administration from the University of Arkansas. And with that, we're going to turn it over to Miss Arkansas.
Hello, everyone. Thank you so much. I'm so excited to be here. I'm just here to kind of kick this thing off and give you guys a brief welcome and a hello and a good morning and happy Friday. So I'm glad it's Friday. But I went to the University of Central Arkansas. I got my bachelor's of business and marketing there. And then I went on to John Brown University to receive my master's of business and healthcare administration. So I appreciate what everybody in this room does. Before winning Miss Arkansas, I worked at Conway Regional Health System as a marketing specialist with their administration team. So I get it and I understand, and you guys are all amazing. And to be here at this conference and really understand what it's about really just makes our jobs and this whole day just that much better. So I want to say thank you guys. But people usually ask me what I do every single day and what my job looks like. My job's pretty amazing. It's pretty crazy. But being Miss Arkansas is a full-time position, so after you win the title, you sign a contract the next day with the board and the foundation, and you're a 1099 contract worker for the entire year. And it's really awesome, though, because I go around and I speak to different organizations. I've met every state senator, state representative. I've worked with both governors and their administrations. I partner with the FBI of Little Rock and the Cyber Crimes Unit and the AG's office, and my picture now hangs in the state capitol, which is really cool. But my job is really amazing. I'm usually in a different city about every single day. So yesterday I was just here in Little Rock, which was nice. But the day before that, I started out in Conway, made my way over to Jonesboro for a luncheon, made my way to Sheridan, Arkansas for an event that night, and then back in Conway. And then today I start out my day here, and then I have another hospital gala in Crossett, Arkansas tonight, which if you don't know, that's South Arkansas. It's way down there. I was there last week too, but I travel quite a bit, so my job is pretty amazing, and it's really just awesome to be here with people like you who are just making a difference in the world and in people's lives and helping them wherever they can. But I'm just excited to be here. And my entire year, I'm almost done, so I've got about a month and a half left of being Miss Arkansas before I pass on my title to the next girl in June. But I do travel a lot, but the thing that's great about that is Vail and Little Rock gives us a car, so I don't have to worry about putting those miles on my own car, because since June of last year, I've traveled almost 48,000 miles, so I am rolling along. But it's really fun, and I get to meet a lot of really awesome people in Arkansas and make a difference and show people that it doesn't matter where you come from or what you look like or who looks like you and who doesn't, but as long as you keep trying and persevering in your life, then anything is possible and you can do anything. And if I can do it from Harrison, Arkansas, which has never seen a Miss Arkansas before, I come from a single mother home. I'm the youngest of three. I'm first generation college student and college grad and master's grad. So thank you. But if I can do it, then anybody can do it. And that's really what I promote throughout my year, as well as doing things like this and speaking and really engaging the next generation of Arkansans and future leaders of our state. So with that being said, I just want to thank you guys so much for joining the conference today. I hope you take away something to go help people wherever that is or wherever you're from. And if you're not from Arkansas, welcome to Arkansas and welcome to the natural state. It is my favorite state, so welcome. And if you're not from Little Rock, welcome to the capital city. So thank you guys so much. Have a great day.
Thank you, Miss Arkansas. What a wonderful story, and thank you for being here with us this morning. And that's what it's going to take, right? We're all going to need to persevere, and we're going to have to work really hard if we are going to be able to put behavioral health integration into all of our primary care systems and really across the health system. Okay. Well, with that, we're getting ready for our keynote speaker this morning. This morning we have Adele Allison, and so when I saw Adele come in this morning, the first thing I said was, "Wow, Adele!" So I have to tell you a little bit about the first time that I saw Adele. I was sitting in my kitchen table, which is the same place that I was sitting when I filled out our nonprofit 501c3 tax forms. So here I am sitting in my kitchen table, and I was eating lunch and thinking, okay, I'm going to multitask, I'm going to eat my lunch, we've got to get these reports out, and I need to listen to this HRSA webinar on interoperability. And I thought, I don't even know what interoperability is. And so here I am sitting down eating, and I started to hear Adele, and I thought, this is fantastic. So I put my fork down and looked at the PowerPoint, started taking notes as quickly as I can, and thought, oh my gosh, this is fantastic information, and it's something that is absolutely critical. I give Dr. Gibson a call. You won't believe this. You won't believe what we just heard. And so that was my first experience with Adele. I actually got to hear her at a conference for HRSA just a couple of months ago, and she was phenomenal. And so we decided to bring her into Arkansas so she can, so she can share some of those ideas with you. And now I'm going to read her official bio. And so this is going to be Adele Allison. She's the Senior Director of Content and Experience for the College of Healthcare Information Management Executives, also known as CHIME, the leading organization for CIOs and senior health IT leaders. Adele Allison develops, teaches, and manages content, programming, speakers, and faculty for CHIME, CIO, CISO, CIMO, and other executive IT providers. Having acted as the co-chair of HHS, ONC, Beacon, EHR, Vendor Affinity Group, Adele served 3 years on the federal work group for electronic data interchange, the board of directors, and 5 years as co-chair for the WEDI Payment Models Work Group. Adele has nearly 30 years of healthcare experience spanning matters of industry, health IT, and related legislation and regulations. A published author, Adele is a member of the University of Alabama at Birmingham's UAB Health Informatics Advisory Board on Curriculum Development and served on UAB's High-Tech Committee for Health IT Curriculum Development under an ONC grant. She teaches policy matters to HRSA FORP grantees, which is us, for the Georgia Health Policy Center, and is the past president of the Alabama chapter of HIMSS. Without further ado, it's my pleasure to introduce to you Adele Allison.
All right, so off we go like a herd of turtles. Yes, my name is Adele, so hello. You know, no one used to be able to pronounce my name until there was a pop singer. And in fact, living in the South, I once introduced myself. I said, "Hey, I'm Adele." And they said, "Oh, it's nice to meet you, I'm Adele." So, you know, anything is possible in the South. But I am so happy to be here. And why is this? It's not working. Or maybe it is the user. So this is what we're going to, you don't have to hide, yeah, I can. This is what we're actually going to be covering today. We're going to talk about mental health by the numbers. This is going to be stuff that you're familiar with way more than I am, because as she already indicated, I'm more of a legislation, policy, regulation analyst. So that's and I probably need therapy because of that. But this was actually some research that I did just to help me really understand what the picture looks like today. So for your purposes of you, this will be more of a level set. I'm going to go from there to talking about the fourth industrial revolution. How many of you have heard of the fourth industrial revolution? Oh boy. All right. This is where we get into stuff I'm very familiar with. Then we're going to talk about transformational leadership. If we weren't already in a Herculean element of change, throw in a pandemic and the burnout, especially from a clinical perspective, and the uptick of everything that resulted behaviorally from that isolation and everything else, you certainly need to embrace change now. Everything is shifting and it's happening very, very quickly. And this will impact your efforts on behavioral health integration. And then we're going to talk about developing high-performing teams. What are the elements of that? What does it take to be a leader? My feelings are, if you're at this conference, you probably are among the leadership within your organization. So that's where we're going from there. And then if you haven't run screaming from the auditorium, I'll take questions at the end. So just kind of starting with mental health by the numbers. Before I get too far into that, I am a subject matter expert, but I am a geek. I was trained at Georgia Tech in systems engineering, telling my age a little bit. I color my hair, thank God for Miss Clairol. I programmed on punch cards. So that tells you a little bit about how old I am, and I didn't go into programming, right? My mother was a registered nurse at Ebony. I grew up in Atlanta and migrated to Birmingham, so I'm one of those that came from out of state. But I am a geek, so what does that mean? Well, as a geek, I created a Venn diagram to explain it. So really, there's three characteristics that you have to look at when you're kind of looking at the difference between a geek and a nerd, and I'm a geek. So if we look at a geek, it has usually pretty good IQ. You know, they're good at math and science. They're a little socially awkward. That is definitely me. I always stick my foot in my mouth. And they tend to be obsessive. So if we look, the sweet spot on this, oh, I'm sorry, I'm a nerd. That's a nerd, okay? They do all three. Now, if they have a high IQ and they're obsessed, so they go to Comic-Con and, you know, dress up and have sword fights and stuff like that, then that IQ and obsessiveness, that is where the geeks live, okay? But they're not socially awkward if they're among their own, right? And if you have if you have IQ and socially awkward only, well, that kind of makes you a dork. And really, the only thing you have to do in order to change that up is just to, develop an obsession. If you do that, then you become a nerd. So, and honestly, the last category, if you're socially awkward and you're obsessed, but you don't have a high IQ, well, that makes you a stalker, okay? So hopefully that in and of itself kind of explains my area of where I come from, okay? So let's get moving, enough about me. I like to start with a quiz because what's better on a Friday morning first thing than starting with a quiz? But it's easy. I have been working in healthcare. If it's 5 years or more, raise your hand. Okay, 10 years or more. 15, 20, 25, 30, 35, 36, 37, 38, how long? 44 years, yeah. And what is your name? What is your name? Ruth. So if anybody needs to know how the earth turns and how this stuff works, Ruth has seen it all. Find Ruth. She's going to know more than I do. Okay, here's my next question. I can put this down, I guess. My number one struggle I practice today is what? How many of you say, I'm burned out? Stick a fork in me. 1, 2. That's surprising. Y'all are just our special people. Okay, how many say, I can't find enough staff? We got a few more on that. Information technology and systems. I'd rather have a rash. Okay. Change and transformation, keeping up with it. We got just a few hands on that. The patients are my biggest nightmare. Okay, we have a couple of hands, but not too many. Y'all are just, how about revenue? Okay. So then that puts a lot of you in this other category. So I'm curious, in this space, in this vertical, what is your number one thing that keeps you up at night? Anybody, shout it out. Too many maybes? Meetings. Okay. Burnout, okay. All right, anybody else? Something I don't have up here? We're in a very difficult time right now, and I think I said that 10 years ago too, but all right, and here's the last one. Is there one thing you wish someone would have told you at some critical point in your career journey that you now know, but you didn't at the time? What would that be? Anyone? Come on now, yes.
The amount of paperwork.
Paperwork. Tsunami of paperwork. Anybody else? What do you wish you knew at the beginning of your career? Jumping through hoops?
How to navigate insurance.
Oh, amen. Who's my Blue Crossers in here? Hey, ladies and gentlemen. And actually, I know a lot of people at your shop because I used to work for DST. So, yeah, now they're cringing. DST is your system, your claim system. So, all right. So, well, that helps me get to know you a little bit better. But healthcare itself needs rethinking. When and this is just a picture from the, physical side of healthcare. And we've come a long way as we've tried on the physical side of healthcare to be more patient-centric. But in our country, there is still this bifurcation between mental and physical health. And it's ridiculous because if you're going to treat the whole person, you got to treat the whole person, right? So we do need to rethink this as we go along. So these are just some recent things that I pulled up just to kind of level set with everybody. When we look, the thing that struck me, and we're going to get into this a little bit, 18 to 25. So if we look at the overall percent of people that had mental health problems, you're at 23%. That's 34% for this younger age group. We're going to talk about that in a little while. Also, if we look at disparities, Asians pretty high. When we look at 2 or more interracial, it's way high compared to the other. So that kind of stood out to me. I'm a visual data person. And these were a couple of other things that, because I know you're talking about substance use, particularly opioids, the fentanyl problem. It's crazy and it's scary. Now, I raised my kids. My kids are I've got a Gen Xer and I've got a geriatric millennial. But my kids went through most of their elementary and the geriatric millennial, to some degree high school, without internet access, without mobile phones. I can't even imagine trying to raise a child today. And we're going to talk a little bit about that. So I like to look at generations, and I probably should start this in reverse, because by the time you get to Boomer, when you hit, or even Gen X is kind of nearing this, you're immortal till you're 30, then you start to have some aches and pains. By the time you're 50, everything's starting to clog up, break, and fall off, and the age-related problems that are coming through here. But honestly, when we think of healthcare, whether it's physical or whether it's behavioral, you could have a patient that spans 6 generations, and actually 7 at this point. So our least generation that's going on is this lost generation. So these are the ones that fought in World War II. They remember the Great Depression, the Dust Bowl. Their music is jazz and swing. They're rapidly decreasing from our population. Then you have the silent generation. So these were the children of the Depression era adults, right? So they were, you don't argue. You do it because I say to do it. They're very conforming, hardworking, traditional values, discipline. Icon is Henry Ford. Then we get to the boomers. That's my generation. Sex, love, rock and roll, right? And our icon's John Lennon, We're known as an indulgent generation. We want to live in the fast lane and then go to a doctor and say, give me a pill and make me better, and not take a whole lot of accountability for our behavior. So that's kind of on this side of the generation tree. Then we go over to this side, we move to Gen X. So they're known as the baby busters, if you will. Some of the people that we have, I should be giving these out. Lost generation, you had Hemingway. Hitler was of the lost generation, thank God. Al Capone, the silent generation. Joe Biden is of the silent generation, just so you know. Elvis Presley, good one for this area of the world. Yasser Arafat, he's of the silent generation. Boomers, Oprah is a boomer. Robin Williams, Obama is a boomer. Gen X, we get into this is Adam Sandler, Will Smith, Tiger Woods, Jennifer Aniston. Now, these people, I have one that's right on the edge of the end of Gen X, but these are the children who remember the AIDS epidemic, the rise of MTV, the Iranian hostage crisis. They remember paper newspapers that their parents read. They remember going to a library and using a card catalog, things like that. You have the millennials next. So in the geriatric millennial, Mark Zuckerberg, Beyonce, Kim Kardashian. And then in the regular millennials, you have LeBron James, Kim Jong-un, Emma Stone, those are some of your millennials. Now, they are known as, so we have, these are a very digital enabled generation. They remember the 9/11. You know, they probably were, a lot of them in elementary school. Columbine, which was the first big shooting. The rise of Google. Y2K, how many of y'all remember Y2K? It was just yesterday, right? They are very focused, their values are very focused on environment. They like digital. They're also the trophy generation. Everybody gets a trophy. Even if you were terrible, you get a trophy. And then you have Gen Z that's coming in, also known as iGen. iGen is very self-reliant, but they are also very digital dependent. So some of your Gen Zs, your younger Gen Zs, can't tell time on a clock face. They have to have digital. Their values are inclusivity, gender neutrality. Now, I've been using this chart for quite some time, and I'm a data, we already established I'm a nerd. So I like data. So I kind of always flash it up against the statistics on our population in our country. And I said, so this starts at age 11. I'm missing a whole group of people here. Who knows what the next generation is? There you go, Gen Alpha. This is the one that's coming up. So this is your children that are under the age of 11. So they are known as digital natives. How many of you have seen a child that's like 15 months old with an iPad? They are coming up. We've got some things right now that are going on from a digital technology perspective that are complete game changers in what's happening. So when we even look back 50 years, which is nothing, when we look back 50 years, it's night and day how our world works, right? So these are digital natives. They are growing up, plugged in, have the most screen time of any generation. The iPad on the back of the car seat, so they watch a movie while we drive to the beach. We don't interact with them, right? They're growing up in a generation where we have falling fertility rates. Most people now are having one child. If I come from a family that is one child, my mother was an only child, so this is not a slam, but do I have to share my toys? No. Throw a pandemic on there. Do I need to socialize with anybody? No. I can get my social time using VR technology or online gaming or texting on a screen, right? Big changes coming here. And AAP, the American Academy of Pediatrics, is already seeing a real uptick in allergies, obesity, and other health-related problems. Now, these things, I would argue, are going to play into behavioral and mental health, for sure, right? But this is your generation that's coming up. So when I overlay the breakdown of the US population, this is how it breaks down. So all of us that have these age-related problems, we don't add up to much anymore, We're probably the most expensive people to take care of just because we're getting old. But this side of the house, the one that's not digital, is going away. And what is on the uprise? Look at where your population sits. That's what it says to me. So just something to be aware of. You may already be aware of this, but it really struck me. So I'm going to dive a little bit more into Gen Alpha. These are just some statistics on Gen Alpha. They are the most socially aware generation that has ever been studied. They are very aware of how my feelings, feel, how, political correctness, what's your pronouns, things of that nature. They're growing up with that. They're the first completely digital generation. 54% age less than 11, so that's your 10-year-olds down. 54% have their own tablets. That tells you something right there. 11% own their own VR headset. It's 18% where they live in a house that has a VR headset. And they use that, if they own it, 7 hours a day. Staggering. And that's virtual reality. What does that mean? Y'all are the behavioral health things, but 55% use social media, 24% have online friends that they've never met in person. They develop their own brand. This is because of the data they generate by age 7. Parents are financially preoccupied in this country because we're a capitalist market. It's all about the dollar, right? And then stress. You got stress? Here's a fidget toy, right? That's how we handle a lot of this. So this is what's coming up. So now, since I've totally, I told you you'd want to run screaming from the room. I'm going to introduce you to the 4th Industrial Revolution. The reason that I'm doing this is I want you to stop and think. Y'all are in the business, or what this whole purpose, as I understand it, so please correct me if I'm wrong, is getting to the point that we have holistic care, physical and mental. And we combine the two because I'm one person that has those parts, right? That's the goal. What I'm telling you is your world is changing right before your eyes. And if you do not account for this kind of stuff in how you practice and how you integrate, this is going to be a very pivotal point that you've got to make to have success. So let's just talk a little bit about Industrial Revolution. So it kind of looks something like this. When we think Industrial Revolution and what they teach us in grade school, you had, I need my clicker? I got to stand over here. See, I'm a walker. That's probably some kind of neurotic thing. When we got to the 1800s, kind of coming in, we had this swell of immigration coming into our country. And what happened was we got steam types of engines. And this created the first industrialized revolution because we could use machines over people. So we started to see factories. A lot of these immigrants then migrated to these urban centers for jobs, for money, right? And that they became densely populated without a lot of health care type things. They got, typhus, they got dysentery, they got things that come about when you are not managing public health, right? So from a technical perspective, during this time, this was actually in the 1800s, they would do census, and to do the census usually took years because it had to be manually compiled. But in the 1800s, they came up with the Holrith tabulating machine. And what it did was it took the census effort of just counting how many people we had from years of calculation down to months. It really automated it from an information perspective. So we move forward a little bit and we get electricity. So as we get electricity, that certainly plays into the second industrial revolution. In 1928, someone invented magnetic tape. And of course, that was the genesis for floppy disks. How many of you remember the floppy disk? Okay, y'all are telling your age now. But yeah, that's what happened there. By 1960, We had the first relational database. Now, what that means is I can come at things from multiple angles. So that was a real big deal, and that's where data started to take shape. So you had tables and data characteristics or attributions. And so we started to look at the relationship of this data to this data. That was in the 1960s. By the late 70s, we started to introduce, it was actually late 70s, maybe early 80s, people really started getting access to a home computer. They were giant. It's where, we really started to see use of laptops at the end of the 1980s. In 82, the internet as we know it really started to take off. That's where it became something that just wasn't accessed by governments. It became publicly available. By 85, we had the first internet domain name registered. And by 1995, we had the World Wide Web. It was there. In 1994, Yahoo was born. And in 1998, Google was born. That doesn't seem that long ago to me. And now Google is a verb, right? Can you Google that? Yeah, I can Google that. We all know it, we use it in our language all the time. Coming into the 2000s, this is where you're hitting your second information revolution, or the fourth industrial revolution. So really the fourth industrial revolution started to hit in 2011. What was a monumental healthcare government program that started, that you had to comply with by 2011? Hospitals and physicians. Do you remember the program? No, HIPAA was 96. I'm looking for meaningful use. Electronic health records hit right at that time. That was the compliance deadline as we know it. So now, since then, since 2011, that's really when they say you hit the fourth industrial revolution. You've now got things like AI, which we're going to talk about. You've got the Internet of Things. I've got the Internet of Things right on my mobile device, right? You've got the cloud, 3D printing, quantum computing. All of that is hitting now. I don't even have to have the infrastructure. It just goes somewhere out there. Well, anytime you do anything on the cloud, it is stored on a farm of servers. Doesn't even have to be in the US, right? But it's there permanently. And we're generating a lot of data. So this is what you're in right now. Now, I do another talk, and Kim may have heard this one too, but I call it the Hippomipatrica macropachycures era. That's what you're in, okay? And a lot of this they're trying to regulate and take control of. So the marks of a revolution, when we think of industrial revolution or information revolutions, there's three marks. First of all, it's less expensive. Let's use an example. I got here today not real well, but it led me to the ER. My GPS. How many of you remember paper maps? Yeah? Fold that sucker down, and try to manage it. Oh, the roads are not even accurate, right? It's only as accurate as the day it gets printed. GPS comes standard on your phone, standard on your car, right? It's free, right? So it's certainly less expensive than purchasing maps, right? The second attribute of a revolution is it's easy to acquire. I get my phone, I get my car, I get GPS. Do I need a paper map? No. They're cool though. If you get the old ones, you can frame them and put them up on your wall. Really cool, that old-timey stuff. But it's easy to acquire. And the third attribute is you have higher quality. GPS, for the most part, is pretty good. Any of y'all ever seen the Google cars? driving around? Have you ever searched and looked at the street view of your own house? It's kind of creepy, but yeah, you know, the big brother watching, it's there. So these are the three attributes, and when we think about digital health, that's exactly where we're headed. So to really sum this up, and I hope this is going to work, I found this video that does such a better job of explaining it than I do. So I'm going to try to just tell you what it shows and invite you. It's a Deloitte video. So what happens is two people are laying in bed in their house. There's sensors in their bed. They, you know, one is showing that the woman's heart rate is a little bit elevated and she has sleep apnea. So it notifies her doctor automatically. Her partner in the bed, his serotonin levels are dropping, so it goes ahead, the AI, and schedules an appointment with his therapy virtually, so he can do it on his phone, easy to do, right? Guy goes into the bathroom, he looks in the mirror, he can see himself, but over here it's telling him his blood pressure and all of, because he wears the O-ring, it's telling him everything that's going on over here from a measurement, how did he sleep, how many steps he did. Now, I don't know about you, but if I had to face that, our motto in Alabama is thank God for Mississippi, because we're like the second fattest state in the country, and we're just so grateful for Mississippi, right? And I am a true Alabamian woman. So if I had to go in and look at my weight and my, you know, the bed's weighing me and everything else, you know, I'm going to need therapy for sure, right? You know, but the future is data-oriented, it is digital, it is right in front of your face. And when we think back, most of us in this room, remembering the time before cell phones and everything else, so much simpler, right? You came home when the street lights went on, right? Or mama hollered, dinner, down the street, right? That's what we remember. Now, my parents know everywhere I'm going, every step I'm doing, and I've got predators on the other side that are trying to get at me because you have no reality necessarily in social media. I mean, we're just dealing with things that we never could have imagined when I was growing up. It's crazy. Okay, let me get back over here. So let's talk about the data that's being generated. So you have patient-facing data. So this is data that within the healthcare system that comes about. You have, Adele comes to your clinic, you're going to have information on me, but it's not interoperable yet. That's a whole other topic, right, Kim? Because everybody's going to hand me a clipboard when I walk in because they don't even have my proper name and address. So none of the data moves necessarily even today from one place to another. We're working on that. We're making progress on that. But generally, within my enterprise that I own and I operate with my systems, I'm going to have questionnaires, insurance information, driver's license, intake information, all of this. This is data that you control within your enterprise, right? Then you have clinical information because that patient isn't just seeing you. They're also going to the ER down the street. Let's turn there it is. They have substance use disorder and they want that, you know, opioid, which, you know, is changing as well, but we have problems with that. Wouldn't it be nice if you got a notification on a substance use disorder that they showed up at the ER last night? Wouldn't that be nice to get that notification? That's the integration we need to be talking about. Population health management is another big one, clinical trials. So all of this is going on. And then you have the administrative side. So I got my blues people here. The most ubiquitous, pervasive information we have is claims data. Claims became electronic by mandate of the federal government under HIPAA. So how many of you remember paper claims? and you made your stacks. And these went to the Blues, and these went to United Healthcare, and I had labels, and I had envelopes, and I shoved them in, and I shoved them in the mail. And then the payer would pull them out and hand key them in. Oh, and then they got advanced with scanners, right? All that changed. We had the ability to do electronic claims, technically, in the mid-'80s. But especially here in the South, we would rather have a rash over 70% of our bodies than do things differently than we've ever done them before, right? So even if it's something we can do, we ain't changing until the government says, oh, yes, you are. And then kicking and screaming, everybody moved to electronic claims. Would you ever go back to paper claims? Can you imagine how many people we put out of work doing that? But we adapted. And that's that digital age. Now, the one thing of speaking to my providers in here, I've worked on both sides of that fence. I worked for a Blues plan. I worked for the Blues of Montana. I was over their provider affairs. So I was the person that decided the rates of reimbursement. It was very popular in Montana. And I've also worked the provider side, mainly, I worked EHR software development in an advisory capacity for 16 years. So I've also worked the provider side. Most people have only done one or the other, and they don't trust each other at all. So when we think about administrative claims data, the one thing I learned working both sides is providers think of their claims as a means of getting paid. And it is, right? But the mental shift you need to have immediately, today, if you take nothing else away from my talk, take this away. Those claims, you are actually reporting data to the people who pay you. And we have demographic information. There's like 400 data points on a claim. Always has been. And your payers who have to manage the risk, they're the ones that use that data extensively. So it's an inch deep. I don't have a lot of data on Adele, but I have data on her. And I want to know if she's sitting on this side of the, risk pool where y'all don't wear your seatbelts, y'all were out till 3 a.m., partying it up. You had to be bailed out of jail to make it to the, meeting this morning. I'm going to spend a lot of money on these people if I'm insuring them, or whether they're over here and y'all ate salad 5 days, 3 meals a day, 5 days a week. Every one of y'all got up this morning and ran a 10K before you got here, right? So y'all are going to be healthy. I'm not going to spend a lot of money on you. So the goal of a payer is to take people who are, you getting bailed out of jail, I'm never going to change your mind. You're never going to comply. But she's on the cusp. You've been influencing her. But if I can move her more this way, she has better quality of life. And I use my claims data to look at this sort of thing. This is what payers do. That's risk management. So the one thing I want you to take away, if you don't take anything else away, is yes, your claims processing is a means of getting paid, but more importantly, it is the way that you report data to the people who pay you. And if you are not telling the people who pay you everything you know, and you answer 2 questions, what did you do? What is that usually? CPT. Why'd you do it? Diagnosis code, right? So, and everybody uses the same code set. So that code is recognized at Blue Cross, it's recognized by HHS, it's recognized by your system, so that data is interoperable, it's electronic. We do not have that yet in clinical data, but they have identified an electronic health information data set. It's the US CDI, y'all want to write that down, right? I told you I was socially awkward. But that's the one thing. Your claim system is actually how you talk to your payer. So remember that. And whoever is your biller, they have a very critical role in trying to work out integration. Make sense? Okay, but then we have everything that goes on outside of your enterprise or even the clinical ecosystem. Now, we do have a medical ecosystem because Adele's a frequent flyer. She goes to, she's the train wreck patient. She has a cardiologist. She has diabetes. She has an endocrinologist. She has substance abuse, so she's going to the ER. I've also done things like Ancestry, where I've spit in the little vial and they've looked at my DNA, so they have genomics information on me. Public health knows when I got my COVID immunization shot. Then we also have this here, patient-generated health data. How many of you have an Apple Watch? Does it generate health data? Yes, very specific to you. Fitbit, another one. But there's also other types of wearables. Your smartphone generates health data, right? And then you have non-health information things. This is everything else you're doing. Now let's get back to that generation alpha, where everything is digital. Am I going to know everything about that 10-year-old as they grow up? Oh yeah, baby. And I'm also going to know how to message them and everything else. And that's where this really becomes critical. All right, so a single individual in the United States generates around 450 megabytes of information per day. To give you an idea of how much data that is, so I'm nerding out on you here. 1 megabyte in data terms is the equivalent of 873 pages of text, okay? So if I have 473 megabytes per day, I'm generating this many pages of information on myself per day. And that's for every person. And we have 330 million people in the United States. Now, this may not be the case in Nairobi, or Nigeria, or Somalia, but it certainly is the case in the US. It's just perspective, right? So let's talk about artificial intelligence. There's 3 things you need to know. The first is you have artificial narrow intelligence. This is really where we are now. So what this does is pattern recognition. They're talking about using this for things like prior authorization, where the system can recognize certain things and go ahead and automate the approval of a prior authorization or kick it out for a human to take a look at. These things are being developed now. So artificial narrow intelligence is really where we are, but we're bleeding into this next one, which is artificial general intelligence. Now this has not, it has not been achieved. It's starting to be achieved. So this is where the machine can cognate like a human. So I can take in and see pattern recognition, and that prompts me to take action in this regard. Or I look at this pattern and I put them together. That's cognition. So that we're in between these two. And then the last one, which right now is only theory, any of you seen The Matrix or Terminator? This is where it becomes self-aware. It becomes an entity of its own, right? So these are kind of the 3 levels of artificial intelligence just to be aware of. The big thing that's happening now, how many of you are familiar with generative AI? Okay, this is just making you aware. So it uses pattern analysis, but what it does is it takes mathematical and computational formulas and applies it to what it's seeing in those patterns and trends. GPT actually stands for Generative Pre-trained Transformer. So by 2025, Gartner Group, which is a huge consultancy around the world, they're predicting that 10% of all of our data in the world will be generated by artificial intelligence, by GPT. How many of you have seen the ad where the little kids are having coffee and they're talking about what they want the internet to be? That's Gen Alpha, okay? They're the ones that are going to make this happen. So ChatGPT is the most prominent one how many of you have ever played with it? It's crazy, right? You type in a query, what it does is it breaks down the entire internet or a medical book or whatever into what they call tokens. Tokens are usually 5-character words. So like if I had hamburger, it would be ham is one token, burr would be another, gur would be another, or pear is one token by itself, right? But what it does is it looks at all of the language that's out there on the internet, which is, exabytes of information, looks at the trends and the relations of those tokens to each other, and understands how to generate language, but it also has access instantly. It'd be like having the internet in your brain. So not only do I know how to communicate that based on pattern recognition, I have access to all that information, right? Creepy. ChatGPT originates from OpenAI. Microsoft has poured $10 billion, they're a partner in that, $10 billion into ChatGPT. There's a bunch of them that are springing up. These are just a few I would note. Glass AI is the big one that they're pegging for healthcare. They've poured medical texts into it or socialized it to medical text. Synthesis AI uses synthesized patient data for predictive modeling and things like that. It does 3D human modeling for physical health. Inflection AI is working to create a human-to-computer type of communication. We're getting into Star Trek where you say, hey, computer, I'd like some Earl Grey tea, right? And it knows exactly what I'm doing and it goes to work. I didn't include on this, they're also getting into imaging. You don't know when you go on the internet what is real. Have you seen the ones where they take George Washington's face and he sings Wellerman? There once was a man who went to sea, he starts, and it looks like he's singing. That's AI, okay? So what's going to happen to us behaviorally or mentally when we buy into something then find out it's all been generated by computer? What does that do to our belief system? This is what is coming to you very, very quickly and why it's so important to integrate the two. So let's look at applications in mental health for generative AI. They say right now the best thing it can support is cognitive behavioral therapy because generative AI is working real hard on context, but what it can't do is look at body language, which is 48% of our communication. Can't do that. Potential applications, diagnostic disease and disorder accuracy, where you could go into ChatGPT. I have a patient that says this and this and this. What kind of diagnosis should I give them? It'll say, here you go. It'll go out and look on the internet and pull it back together and feed it back to you. Personalized medicine, so analyzing genomics, drug efficacy, identification of patients in crisis. This is getting into your modeling by using linguistics. If I have a voice record and I hear quivers in the voice or certain things like that, it can recognize that I've got a patient in crisis, which could be very helpful in suicide, right? Timely and relevant psychiatric research, distribution or mental health resources. So there's a lot of good that can come out of this, but anytime we fix something over here or improve something over here, we usually create new problems over here. So just be aware. If you're going to use it, this is my personal belief, if we are going to integrate generative AI into mental or behavioral health, it needs to be with a certified mental health professional. I think it could go sideways real quick. So there you go. As told you, you're going to run screaming from this room. So let's talk about all this change and what we need to do from a leadership perspective. There is a difference between management and leadership, and you need both. And I would even say a manager could be a leader, right? So management is the planning and the budgeting and the organizing and the staffing for a process, controlling and problem solving on a day-to-day basis. My leadership is the one that comes up with the vision and make sure everybody knows that vision and they keep that in the forefront of their minds as they are trying to problem solve. They're the ones that align people, help with networking, and they motivate and inspire. So your leader is someone, let's use electronic health record, we're putting that into our office and we get the I'd rather have a rash response, right? Well, the leader is the one that is going to say, this is going to be hard. It is going to create chaos. You're right. But at the end of the day, we're going to be able to do X, Y. Here's the vision. Here's how it's going to make your life better. And you can have official leaders, like the CEO of a company, and you can have unofficial leaders. And those are easy to usually call out. The person in the office that everybody respects and trusts. So you need both types of leaders. The larger the change, the more leadership you need, because change is hard. Now, for sake of time, I'm not going to read this to you because will have a copy of this. I have added some things to this PowerPoint that weren't in the handout. I will provide an update. I always do that, I'm sorry. But this was generated by Mayfield. Mayfield is a VC company, and it really struck me on what attributes you need as a leader for transformational change. Couple I would point out here is adoption of resilient technology. It's becoming less, especially as people are becoming, the younger generations are joining the workforce. But getting through the plunge of disillusionment into the slope of enlightenment and the plateau of productivity, you need leadership in that. Empathy and understanding. Change is hard. We have so much that's changing so fast, it's overwhelming. And so how do you eat the elephant? One bite at a time. If you have a massive product, and this is the engineer in me, take an iterative design process, do a little bit, normalize, learn your lessons, build. Do a little bit, one step at a time. That is the best way to embrace change, and some people are still going to have problems with it. You have to be empathetic, you have to be understanding. And intentional team socialization. One of the things I think people don't do enough is celebrate their success. Now, I hope with this particular group, after years of trying to accomplish just even getting a conference with a pandemic and Zoom meetings and everything, I hope that you do find a way to celebrate your success. I mean, I don't know. I'm a refined sugar fan, so, cookies on Friday lines right up with me. It doesn't have to be big, but when you hit milestones, don't forget to celebrate that. A few others, asynchronous work. I'm sorry, my margins are off here. Asynchronous work is that remote workforce. How many of you have workers or yourself work from home? Look at that. And I think that's the new normal, right? It was accelerated tremendously with the pandemic. But with the digital age that's coming upon us, it's going to be even more so. So, reduced hierarchy. Now, this one kind of is interesting to me. So I work for CHIME. CHIME is the organization that certifies. It's the hospital CIOs and Chief Information Security Officers, CISOs. So if you have a certified CIO or a certified CISO, it was CHIME that did it. for all the hospitals in the US, and they're in 57 countries. Now, what I did, I have worked the provider side, but it's outpatient. What I have learned is that there is still very much a hierarchy in a hospital. So the more you can flatten that, the better it will be. Developing high-performing teams. When you think about it, you got to choose whether you're going to work as a group or a team. And let me explain the difference. It's not saying a group is not correct. So in this picture, this is my administrative side of my clinic. I've got somebody who does intake. I've got somebody who prepares the bills. I've got somebody who answers the questions on the bills. And I've got somebody who administers all of the administrative stuff. And day to day, they do their jobs, they do their jobs, they do their jobs, right? But this person really doesn't understand how the information she puts into the computer is going to make billing successful and lessen the number of questions we have. They're not necessarily interconnected. Any of you ever watch, we just had from Alabama, Talladega was just this past weekend. Any of you ever watch a pit crew? They can change all tires on that car in sub-seconds. And everybody has one job. I'm the one that goes in and removes the lug nuts. Zip, 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 zip. If I don't do my job, what happens? We don't get them out in time. We don't hit the numbers. We're not productive. A pit crew is what you're aiming for. Everybody not only understands their job, but they understand how it relates to the next step in the process or tandem steps. So first of all, you want a team. So the 4 stages of team development, you've got forming your team. I've got a project, integration of behavioral health. We're going to have a purpose, set the expectations. We're going to have performance measurements. We got to build trust among the teammates. We can do that with fun things. And then the excitement builds, right? Hype, hype, hype. It's going to solve everything and cook my dinner on Thursday and get my laundry and everything else. Then you go from forming to storming. You take the larger goals, you break it down into smaller tasks. And this is where people say, I've never had to do it that way before, right? So you have to be good at conflict management at this point. You want to constantly clarify the key team goals, keep that vision in front of them. The next thing is norming. So now that we've got this live and going on, we want to tweak it, get the teammates to gel so they all can be like a pit crew and come out. And then the last thing is performing, right? You should have a satisfied team if you've done this. They're committed to the mission. Your new normal is successful. So these are the stages of a team. Wrong way. And then to sustain change, you want to anchor always back to a particular purpose, your vision, define value measures, digitize the value change, become transparent. Transparency is the best way, you know this, y'all are mental health people. That's the best way to build trust. Inventory your capabilities. If you're missing something to accomplish it, how are you going to fill that gap? Communicate constantly, own the narrative, and once again, I tell you, celebrate your success. Very important piece of this. And am I out of time? I'm not. Okay. I'm going to wrap this up with a story that I heard from my former boss who just passed away in December. And this really resonated with me. This is actually a true story that's told by the Jewish people about a rabbi 2,000 years ago in Rome. Now, who knows anything about the Jews and the Roman Empire 2,000 years ago? Did they like the Jews? No. Did they enslave them often? Yes. They treated them like sub-people. Now, do we have some of those same dynamics in the U.S.? Yes, we do. So humans are humans. We don't find a lot of change. But anyway, his name was Rabbi Kiva, and he was very committed to his community. And he would go out every day and he would visit people that were part of his community and he would pray, and they would study scripture and all of this. And on his way home, back to his wife, he would take a path, and he would pray and meditate and all of that. And one day he got particularly deep in thought, and he took the wrong road, wrong path. And he kept wandering, and he ended up coming upon a Roman garrison. And at the top of this garrison was a Roman soldier. And he hollers down, "Who are you, and why are you here?" The rabbi didn't hear him because he was so deep in thought. So the Roman soldier says, "Who are you, and why are you here?" So he snaps out of it, but he still didn't respond. So the soldier says, "Who are you, and why are you here?" And Rabbi Kiva looked up, and he said, "Well, who are you, and why are you here?" And the soldier said, "I am a soldier of Rome, and I am here to protect this garrison." So Rabbi Kiva thought for a minute, and he says, "How much do they pay you to stand up on that garrison and ask those questions?" And the soldier looked down, and he said, "They pay me 2 drachma per week." And he said, "Well, I will pay you 4 drachma per week to come to my house and stand outside my door and ask me those questions every day." Now, who am I? Why am I here? I drove from Alabama last night to come in here. I do a lot with HRSA because it has a real special place in my heart. I am married to a man for 41 years who just got diagnosed with high-grade cancer. I have a niece who is autistic. I have another niece who has Asperger's. I have a brother who is a disabled Marine who has severe PTSD and hung himself. He made it through. He had substance use problems, which is typical. I had a father who passed away from ALS. I'm a patient in this system. I'm a person in this world. What you are doing, the reason you got into this, it's so easy to lose sight of that. So easy. Because of the Hippomipatrica-Arapaka-Macrocures Act and everything else that gets thrust upon you. Every day, ask yourself those questions. Who are you? And why are you here? Why are you here today? What are the things you want to take away? That, 1 or 2 things, you don't have to, it could be 80-20 rule. I retain 20%. But that's an improvement, right? And the more that we come together and do this and recognize why we got into this business to begin with, the more we can truly change the world for the better. And that is all I have. Questions?
We've got a few minutes for questions. Do y'all have any questions you'd like to ask Adele?
More than you ever wanted to know. I'm sorry. I am a nerd.
What was the rabbi's name?
Kiva. You can look it up. A lot of people use it like in sermons and stuff, but it's so grounded in truth, in my opinion. But it's Kiva, I think is his name, Rabbi Kiva. Any other questions?
Can you repeat the act again, the
Hippomipatrica-Arapaka-Macrocures slow. HIPAA. Okay, and understand, so legislation, Congress meets, I'm taking you back to 8th grade, Schoolhouse Rock here. Congress meets in 2-year congressional sessions. We are in the 118th U.S. congressional session. So every 2 years, there's an election, and some of them are on different cycles of when they get elected. We have the House and we have the Senate, right? So those people, especially with the polarization that has been brought about by a lot of things, including heavily, in my opinion, by the media and things being taken out of context, and it's just a mess. Congress, I think in the 100th and 16th U.S. congressional session, they had over 26,000 bills that were sponsored. And so that's your laws. Now, there were 23 members of that congressional Congress that did not even have a college education. But they're making your laws. But they're peers, right? So I'm not arguing that that shouldn't be the case. But just be aware. And so they usually when a bill gets sponsored, then it gets sent straight to committees. They've got all these committees, and they argue, and they discuss, and they modify, and they tweak. And one of two things is going to happen. It's either going to go to the floor for a vote, or it's going to get tabled, which means it dies in committee. In that year with 26,000 bills, only 2% got actually sent to the president for signature. So you've heard it takes an act of Congress. Okay, that's where that comes from. Congress, and that's why they all have ACT after it. The Affordable Care Act, the American Recovery and Reinvestment Act. And that's a framework. So if you take the American Recovery and Reinvestment Act. Thank you. I just lost my word. If you take that, there's 60 pages in there called high-tech. Any of you heard of high-tech? That's what legislated and required the meaningful use program. Now, that's your framework. So incentive, you had to be a meaningful user. Well, what the heck does that mean? That's the details. Details of any law comes out of the White House. President comes in, he has a cabinet of close advisors called, most of them are secretaries. You have Secretary of State, you have Secretary of Defense, you have Secretary of Health and Human Services, which is over all of healthcare. There are 12 agencies under HHS. HRSA is one of them, CMS is one of them, ARC, FDA, there's CDC, you have all these agencies, and that's where the regulations come out. So the legislation doesn't change that often because it takes an act of Congress, right? But the regulations change constantly. And a single regulation can be 500, 2,000 pages. So that's where I say HIPAA, legislation hadn't changed. Moving to ICD-10 was a regulatory change. The regs change constantly. What does it mean today? So you have HIPAA, MIPA. MIPA was e-prescribing. HIPAA, MIPA, TRICA. TRICA was reporting electronic clinical data to HHS. HIPAA, MIPA, TRICA, ARA. ARA was high-tech, getting on in EHR. HIPAA, MIPA, TRICA, ARA, PACA, Patient Protection and Affordable Care Act. HIPAA, MIPA, TRICA, ARA, PACA. MACRA was the federal government getting into alternative payment models where I'm not paying you based on productivity. You do something and I pay you for it. I'm paying you based on analytic data, the outcome. That's the new payment model that's moving in. So that was MACRA, and that law was only 95 pages, just so you know. But so it was an easy read. HIPAA, MIPA, TRICA, ARA, MACRA, PACA, Cures Act. So the Cures Act is now upon us. They're focused on interoperability of this data, particular in the form of patient access. That's what they're trying to solve. And then we have No Surprise Act. We have, it just continues. But yeah, you're in the middle of it. Does that help you? Okay.
Can you talk a little bit about TEFCA?
Yeah. Ooh, anybody know what TEFCA is besides this guy? Okay, so one of the biggest barriers in moving electronic health information, and that's actually a term, EHI, electronic health information, is defined by regulations. So if you want to look at the data that's supposed to be interoperable, like claims data, where I can get it, look at the USCDI version 1. What does that tell you? It's going to get bigger, right? But that is a data set that all certified electronic health record technologies should be able to produce in a FHIR API format. So that's your data set. So let's say that there's data, one of them's medication list. We're talking about, drug abuse. I want to see the medication list. I can get that electronically. Or a notification, like I said, that my patient ended up at the ER. I need to know that, because they attempted suicide or something like that. Making that information available to you, that's a use case. What TEFCA does is everybody has a cell phone, right? How many of you have your cell phone right in your hand right now? Yeah. Okay, speaking of the digital age. The problem that we have is HIPAA governs privacy and security, so the Cures Act said payers and hospitals and providers, if the patient says they want their information, you have to release it to them. And it's like turning on a spigot. So once I turn it on, any new information, claims that come in, any notes or whatever, I have to, and you have to look at state legislation on when there's sensitive data and stuff like that. We're getting into areas of mental health. But you have to give that to the patient. Now the patient may say, I want the Blues, I keep pointing at you guys, to give me my claims information because I'm about to have a procedure and my benefit information, and I've got this third-party app called Deductibles or Us that can take all that magical information and tell me my out-of-pocket's going to be $537.62. It will give me a pretty good idea of what I'm going to have to pay because I don't feel like I get that from my payer. That third-party app is not a HIPAA-covered entity. So now Candy Crush knows my depression status. Okay? That is why we have TEFCA. So what TEFCA did, recognizing that's governed by the FTC, anything that comes out of a HIPAA-covered entity to a third-party app, which we all use, how many of you play games on your phone? And it says, I want access to your contacts and your pictures and your blood type and your number of children and where they live and, and we say, okay, as consumers because we want to play Angry Birds or whatever it is you play. So I give all those permissions. Well, what TEFCA does, came out of the Cures Act and it told the ONC, gave them broader convening powers, that you have to create a common agreement. Stands for, the CA is common agreement. It's the infrastructure and the common agreement, the governance agreement on that data, so that it takes, if I, Blue Cross, am going to share with Deductibles or Us, they have to be party to that common agreement, which brings them into HIPAA-like compliance. Does that make sense? Long answer. I can't say anything in 50 words or less. Anything else? Yes?
The digital health video that you were going to play, where can we find that?
I will provide the URL for that. It's really a cool video. I'm not promoting Deloitte in any way, but they did a good job kind of showing you. I can remember I went to Georgia Tech in the very early 80s, and I can remember going to Lenox Mall to a movie theater, and AT&T had a ad that they played where they showed someone walking up to a kiosk to buy their tickets and looking at a handheld phone, and I was like, oh, right. My gosh. And, it came true and exceeded. And so that's why I say it's really, it's hard for us to, that's why Da Vinci was such a genius. The things he conceived of wouldn't have even entered anybody's head when at the time that he lived. That's a genius, right? So it's good to kind of look to the future because it'll hit you before you know it. It's like a hockey stick, the doubling rate of technology. It goes along and it's doubling. 1 + 1 is 2, not much, that's not very big. 2 + 2 is 4, still not very big. 4 + 4 is 8, 8 + 8 is 16. So it's going along. It's, by the time I notice the change, the doubling rate goes like this. And what I'm telling you is the digital health stuff, the generative AI, you're entering the hockey stick. So you need to be aware of it. And what does it mean? And we don't even have interoperability, true interoperability in healthcare. So it's going to be a mess. Any other questions? Well, I hope that was helpful.